for this left side of the bow tie, we have financial institutions called hospitals that they benefit from doing the sick care system, right? Sick care services. What bow tie aims to do is to create the basis of an institution that benefits financially from preventing these chronic conditions. Our goal is for all of our members never become a patient.
Welcome everyone to the Freedom Hub Health Biz and Politics Show, Cash Patient Free Market. It is Wednesday, and we have a good show for you today. If you are new to the channel, of course, let me take you to our website so you can see where we post things and check out who we have each week, what's coming up, where to find what the media channels are, and so forth. So here on your-mp.com, your marketplace for health, wealth, and freedom, a number of tabs: home, your health. We've got some good health things there. You can help you take control of your health a little better. Your wealth, but let's go over to your media hub. And that's where, if this clicks through, you will see our Zoom webinars that we have each week, Wednesday's show and Thursdays. You can subscribe right here. We do recommend it if you haven't yet, just so you can get these each week and see if the speaker's of interest to you. Thursday's show, of course, is a little more out there. It covers regulatory capture, other things, not just health. Down at the bottom, you will see our media channels, upcoming guests. Sometimes we do manage to post them. And these are the channels, the links, so you can go to BitChute, Brighteon, YouTube sometimes, and Rumble, where we post the shows by the next week. So with that, and you can buy us a cup of coffee if you'd like. We love coffee. Let me go to the top and stop the share. And Charles, you can introduce our guest in the show.
Great, and I will share my screen. And let me click there and drop these Zoom controls. Our guest today is a very accomplished surgeon and educator in the medical field. He is the founder and CEO of BowTie Medical, that he'll tell us more about, and the host of a podcast with a very cool name, Why Can't We Have It All? So he talks about all things medical, and what attracted me to Firouz Daneshgari as a guest was some posts of his about the inefficiencies, and we would say at Freedom Hub, the corruption in hospitals. As a former Republican congressional staffer, I flirted with efforts with my bosses over the years, especially in the 90s, with repealing the certificate of need protection that hospitals enjoy in about 30 of the states. Still 30 states have repealed it, or less than that. But if we did have a free market in hospitals, it would look more like Oklahoma. I think in Oklahoma there's no con laws protecting incumbent hospitals from competition, so they have a lot of specialty hospitals. And a surgeon friend of mine was telling me how advantageous that was for the best surgeons. They could really have a home in a hospital geared towards their niche. He has been a medical school professor and chairman at various universities, Case Western. He's founded institutes mainly around urology and surgical techniques, which led him to actually founding a program at the renowned Cleveland Clinic. And the topic today isn't just about hospital protectionism, but I think politically we're going to get into why we should care. And I think the COVID hysteria over the past couple of years should give everyone a reason to go protest in the streets. I mean, Robert F. Kennedy, even today in a podcast, was talking about this 2019 study that Fauci was involved in comparing remdesivir as a treatment for Ebola. And remdesivir had more deaths than Ebola, and they terminated the Ebola study. And remdesivir kills your kidneys. And that's what everyone got in the hospitals. And then New York just published this study that intubation was a death sentence. I think most of us who follow healthcare know that hospitals, even before COVID, were drumming maverick doctors out of a job with sham peer review, something that Association for American Physicians and Surgeons is very hot about. And they would bully patients who didn't follow protocols. Mothers will tell you about the bullying they face to, get their babies over injected for this or that. And our co-host Jim himself with Pavilion is intimately involved in the disruption of hospitals to bring hospitality and integrated care into them. So Firouz, you have a lot of people in this universe with health freedom and health reform that really want to get aggressive on this issue because we're sick of the cartel. Now, it seems to me you have a bit more of a mainstream approach to this, from just the inefficiencies, the malincentives to overutilize, or some friends say the lack of outcomes on whether this works. I know at the health plan where I work, we struggle with tools to help patients shop on bundle pricing or find quality physicians. So the quality is still an open-ended discussion and how we find the best surgeons. And with that, I will stop my share and let you tell us what we should care about on this issue.
Well, thank you very much, Charles, for the invitation. And I think the best way for me to get into the issue is share with you a little bit about my background. And hopefully to communicate this, that the way I arrived at this, basically where I am now, is you're correct, through a scientific approach from a surgeon scientist perspective, who's spent his entire life, his entire adult life in healthcare since the age of 17. From the technology or from the technical perspective, I arrived at the root causes of why the problems that you mentioned exist in the system. And again, from the technical perspective, from a professional scientific perspective, how could this be remedied and cured? And as you know, I have published the book. The title of the book is called Health Guardianship, the Remedy to the Sick Care System. So and that has brought me actually toward your cause, and that is in order to create that technically advantageous, efficient model of the healthcare, we need to embrace the roots of a free market in healthcare. So that is how I think our interests have converged, and some of the things that I have published, got your attention. So let me go back to kind of my process of discovery. And this is just simply because the process, and they say the path dependency, when you identify the genetic roots of a condition, you understand the condition much better. So I was born in Iran. I'm an immigrant, and I say to my colleagues that a good part of times the immigrants are more American than the American themselves, because they have seen the contrast. And I think that is where really my attraction to your cause comes in. So I was raised to capture the top of the mountains in my career, and I did. In a short few years, I became a very successful surgeon scientist. I was trained at University of Chicago, in Colorado, UT Southwestern, came to Cleveland Clinic to start a new field, which was my first startup, as I call it, to combine the two areas between urology and gynecology that was later named as female pelvic reconstructive surgery. I set up the first program, and that became very successful based on the very simple concept that I observed during my training, that at the end of the day, patients don't care what ologist they go to. They just care to go to a doctor who's competent and can take care of their problems. So with that one, I went through the next step, which was becoming chairman of a couple of departments. That program became very successful. Therefore, they asked me to serve on the board of a health system that was composed of about 11 hospitals, hundreds of outpatient facilities, and it was about worth of $3 billion revenue. It was during that time of my serving on the board, my eyes opened that basically what we call a healthcare in this country is delivered through 5,000 hospitals. And each hospital is a financial institution. So very much like any other financial institution, whether you're producing products, shoes or chairs or tables, or you're providing services like the airline and everything else, the hospitals have turned into financial institutions that, in the words of the CEO of this health system that I was working at, that if they don't deliver the margin, their targeted margin, they won't exist. So this was my first discovery, and therefore I said, I need to understand this business model because my understanding of this was very different. My understanding was that the reason I became a doctor or a surgeon was to help people to remain healthy. But now what I'm saying during the board meeting is what the key production or the performance indicators, the KPIs, are nothing but clinical volumes. How many surgeries we have done, how many labs we have basically ordered, how many imaging studies, how many diagnostic and therapeutic things we've done, because those drive our revenue and the revenue drives our margin. So I went to business school with this basically understanding, I want to understand this, and I soon discovered in this business model, we are the most expensive healthcare system in the world. We are spending at least twice as much as Europeans or Japanese. This year, we're spending over 13,000 per capita. The worst case scenario, they're spending 6,000 per capita. That's number one. Number two, our outcomes, our health outcomes are worse than all other peer groups. We rank actually in some of our health outcomes close to more the third world countries than the first world countries. So in the economic terms, we are something expensive and mispriced. Meaning we are paying twice as much as the price, we are getting less than half of the value. Then the next thing for me as a surgeon scientist that I was used for 30 years, how to go from unknown to known, how to discover the information, was why are we done in this country? We don't know how to run an efficient healthcare system, or what is? And without sharing you all the details, realize these are independent research that I didn't do, other institutions have done, and 50%, 50% of what we do in the healthcare system, in this hospital-driven system, is a waste. Waste means we do things that makes money for the hospitals, do not provide the desired health outcome for the consumers of the healthcare. So that was the first discovery, and then I went through this process. I learned, okay, if you go back 67 years ago, there were the doctors who were independent, and there were hospitals where if the doctors wanted to admit the patients, they would admit to that hospital. They had privileges. So the hospitals soon figured out, in order for them to make more money, they need to hire the doctors, become their employees. So they started employing the specialists during the 60s and 70s. Then they realized in order for the specialists to basically have cases to operate on or to do procedures, they need to own the primary care physicians, because the primary care, the good old family doctor sitting in the neighborhood, is the catchment area. When you and me and our families, they need something, we go to our primary care. So during the early 90s, they started buying all the primary care practices to basically control the food chain. So through this process, a significant misalignment has been created in the system. The doctors going from an agent or the caring for the member for the patient that needs them, now they have become employee of the financial institution. So I saw this with my own eyes. As a board member, I go and purchase the primary cares in the geographical area we were targeting. The first conversation is, hello, doctors, you've come to our health system. Congratulations, these are your salary, these are your bonuses. 2 weeks, 3 weeks later, I'll show up with a number of MBAs and tell them, guys, the number of the patients you're seeing per day is too low. It's not gonna make your salary. You can't just see 15, 20, 25 patients a day. You need to start seeing 40, 50, 60 patients a day in order to make the salary. And they say, well, we can't take care of the patients if we have 8 hours, 10 hours a day. We said, now you're a part of the system. You don't need to basically troubleshoot all the stuff there. As soon as a member comes in my area, urology, has a little blood in their urine, don't treat them with antibiotics, send them to me so I can do a cystoscopy, CT urogram, blah, 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 blah. And I would, on the surface, I would sell it that, oh, I'm taking a much better care of the patients. But in the background, I knew the reason I was doing that because at the end of the month, at the head of the urology, I had to go and report to the CEO and the executive committee how much clinical volume we have generated. And you take this from head to toe, from neurology to ophthalmology, cardiovascular, and so forth. We have created this cycle of basically using people's health needs to generate revenue for the hospital. So our alignment, the historical alignment that physicians had with the patient has basically become misaligned. This space I use my hands is if you were my patients and I was a doctor 100 years ago, we lived in the same neighborhood. We bought from the same grocery store, bakery, and so forth. When you came to me or when you came with your family, I knew all the information about you. This is space upon which this $4 trillion industry has been built, now has been separated by at least 20 intermediaries, have made it most expensive, unaffordable for the consumer, intolerable for the doctors. Those doctors that I tell you that, I went and told them you have to see 40, 50, 60 patients a day. 3 months later, they'll call me up. Some of them are my friends, says, Firouz, I hate doing this. I can't deliver the services I want to do. I've become a cog in the wheel of a financial institution, right? So that was the first misalignment. The second misalignment I discovered during my work at the business school is about 70, 80 years ago, we were faced after World War II, who's going to pay for the cost of the hospitals and the healthcare? Europeans had gone to a single payer system because they were competing with the socialist system in the Europe. Here, President Truman brought the single payer system to the Congress. It didn't go through. The hospitals and the doctors disagree with it. We created a employer-sponsored insurance for 2/3 of Americans, over 220 million Americans that get their health insurance through the employers. And in 1965, we created the Medicare and Medicaid for about another 100 million Americans that are old, poor, disabled, and so forth, the government provides. So a third-party payer was introduced to this interaction between the doctor and the patient. The impact of the third-party payer is that the third-party payer is paying for this waste of the hospitals out of the pocket of the employer and their employees or out of our tax dollars. So as Friedman says, no one spends your money better than yourself. So we basically gave the control of spending our healthcare dollars to a third-party payer, the insurance companies or the federal government. And that's why the hospitals, there's no end for them how much more they can do. I live in Northeast Ohio. There are 2 big health systems here. Both of them were my employers. When I joined, I will name them. When I joined Cleveland Clinic in 2001, the revenue was about $3 billion. This year, they passed $12 billion. And they announced a $1.2 billion net income for the first half of the 2021. The other system, which was the university hospitals, At that point, they were less than $1 billion in revenue. Now they're over $5 billion in revenue. The question is, over the past 20 years that I've lived here, has the health need of the people in Northeast Ohio increased by 400%? Or their sickness need has increased by 400%? Answer to both those questions is neither. The fact is, these hospitals continue to do more and more and more. That's why they have grown in their revenue. And more and more and more is getting paid out of the pocket of the employers and employees in Northeast Ohio, and for the federal, from the Medicare fund. So that is the second misalignment I discovered. The third misalignment is the consequence of this, that when I go and become a worker for a company and my employer gives me the health insurance, I have an insurance card. And I think someone else is paying for that. Therefore, when I go to the hospital, they have me sign a white sheet of paper that I'll pay for everything you charge me, regardless of whether I've seen the bill or I know what the charges are. Nowhere in our lives we do that. Nowhere we go and sign a white sheet of paper and say, I'm going to pay for everything. Therefore, when I go to a hospital, I don't ask how much this MRI costs. The research shows that the plenty of the services that are provided by the hospital cost 4 to 10 times more than independent facilities. In Northeast Ohio, 5 miles from my office where I sit, you can get an MRI for your head, back, knee, whatever. If you go to one of the hospitals, they charge you $4,000 to $5,000. If you go to an independent facility, you will pay less than $1,000. You'll pay about $400 to $500. But the problem is the consumer has become insensitive to this, and they never even ask for it, right? And therefore, these three misalignments has created this vicious cycle that there is a financial institutions, we call them hospitals, they make more, they do more and more and more. They have no responsibility to the end user consumer because they're getting paid out of the third party payer. And the consumer has this delusion that someone else is paying for. And the fact is, no one gives free money to employers to provide healthcare to their employees. That comes from the bottom line of every company. So from the numbers are, the average income of an American employee is about $25 per hour. $11 of that goes toward the healthcare. So it doesn't go to their pension plan, it doesn't go to their education, it doesn't go for their food and so forth. That's why it has become a significant disadvantage for employers, American employers, to compete at the global level, because they're paying for a very expensive and mispriced system. And by law now, after Obamacare, they must provide if there are more than 100 employees. And frankly, even if they have less than 100 employees, which is the largest portion of the employer market, because of the tight labor market, they must provide the healthcare. Otherwise, they can attract the talents. So this vicious cycle has come to when I arrived at this, I realized I have become a cog in the wheel of this sick care system. A sick is not a healthcare system; it's a sick care system that benefits from population being sick. So I'm going to stop there and tell you how I came up and why basically I transitioned my career from a very successful academician, the chair of a department, to become an entrepreneur, to found a company called BowTie Medical, to reverse this concept. Because again, as an immigrant, I truly believe in ingenuity of the American people. Because as Churchill said, at the end of the day, we find the right thing after we've tried everything else. And I have devoted my career and my life saving and so forth to reverse this, to fix this, because I believe in that ingenuity. This is how in this country we create value, we create wealth. And if you don't believe me, look at the 4 companies who started from garages, literally garages, over the past 40 years, Apple, Google, Amazon, Microsoft, and they're over $1 trillion, where the large giants such as IBM and Walmart and so forth, they were asleep at the switch, as you call.
So you're going to tell us how you got into BowTie Medical out of this and what
Sure.
BowTie is doing?
Sure. So the concept was, as I said, there were three. I will summarize. We are the most expensive system in the world because 50% of what we generate is a waste. The reason we generate that waste perpetually and continues to do is because there's these three misalignments. The misalignments between basically the doctor and the patient has been created by more than 75–80% of the doctors are now the employees of the hospital. Misalignment number two is the third-party payer is paying for this waste out of the pocket of the consumer. Number three is the consumer has become insensitive to that price variability, to that pricing. So the concept of the BowTie is really to reverse those misalignments. And so number one is the primary care is 90% of the need of a population. So I started by providing primary care, not based on a fee for service, but based on the subscription model. You pay whatever it is, $50–$60 per month, and you have 24/7 unlimited access to the doctors. That secures the income for the primary care, but for what buys for you is the time. So the doctors in a subscription model, that's called direct primary care and so forth, they go back to the roots, they troubleshoot, they help you to understand why you're gaining weight, why your blood pressure is not under control. They're not the referral machines where the primary cares who are inside the hospital system, they have become the referral machines. If you need to see 60 patients a day, you only have, and this is the statistics, you have less than 5 minutes to see the patient. And the 5 minutes, you either are going to give them a prescription, send them for a lab, or refer them. You don't have time to troubleshoot. That was number one step. What we did at BowTie Medical right before COVID, we said 90% of this interaction between the doctor and the patient is really exchange of information. We started converting our primary care offering to a virtual primary care. And of course, COVID came and validated that concept significantly, that a lot of interaction between us can take place basically virtually. So we provide a virtual primary care in 30 states. The next level was, how can I engage the person into a process of, it is much better for you and your employer to go and get the MRI for $500 rather than $5,000. So we created a group of nurses, medical advisors, and so forth. We call them the Guardians. The Guardians are equipped with helping to do price shopping, to do the quality check between the referrals. So our team of the doctors and the nurses, we no longer call ourselves doctors and the nurses. We call ourselves health guardians. Means we are here to guard your health and your wealth by A, providing 90% of the need you have, B, to help you to make the right decision that is good for you and your family when you need. If you need to go see an orthopedic surgeon for your knee pain, we're going to tell you, Charles, these are the 3 highest quality orthopedic surgeons in your neighborhood, and these are the prices. You choose, because we believe you have to be in control. You have to be in the driver's seat for making decisions for your health needs and how to pay for it. Then with that, we provide that service to the employers. We encourage the employers to become self-insured rather than buying the insurance as a full insurance from the insurance companies. Be self-insured. We have created a self-insurance package that employers can join. And the reason for the self-insurance is technicality-wise is because it creates transparency of where the drivers of the costs are for the employers and how they can basically saving. And in that process, we create a realignment between the employer and the employees. Now the employee knows that when I go and get an MRI for $500, not a $5,000, it saves money for my company. And through this alignment, my employer is telling me that if you save me this money, I'm going to add to the benefits that I'm providing to you, whether the benefits is increased raise, whether the benefits is provide you, an hour a day to go and exercise, or provide, give you for your, for your gym membership and so forth. So this realignment, as you could see, first realignment between the doctors and the consumers of the healthcare, you and I, members. Next one is to educate, empower the consumer with the information, they make the right decisions for them. Number three is realign the interest of the sponsor of the healthcare with the consumer of the health. So that is the package we currently provide to employers at BowTie Medical. And there is a concept behind the BowTie if you're interested. As you could see, I'm wearing a bow tie, which kind of initiated the concept of the name for the company. But if you Google the bow tie, it's called the risk management style. And the concept goes back to this. The knot of the bow tie in the center is an event that is possible to happen. And it's a hazardous event. It's a chemical spill, fire, airline crash, me becoming obese or becoming diabetic. Health, basically health risk, right? In this BowTie model, we have two choices. One is to wait for this event, for this hazardous event happen, and then deal with the consequences, the left side of the BowTie, as I'm wearing mine. Or we say, no, this is possible. Therefore, I'm going to do whatever I can do to prevent this. And both in healthcare and in other industries, we have done basically both approaches. In healthcare, 100 years ago, the infectious diseases were number one cause of death. If you remember, right? In 1905, 1910, we soon realized in order to eliminate the infectious diseases, we can go and do clean water, clean food, vaccination, right? Within very short couple of decades, we eliminated the infectious disease as number one cause of death, right? We did this preventive strategy and we opened the public health, and we're spending very little, less than $100 per capita in basically eliminating number one cause of death in our country. In other industries, airline, 120 years ago, very first flight took place here, from Ohio, December 3, 1903. In airline, this industry said, the airline crash is a possibility, but it is very undesirable, right? What the airline industry did, focused their entire attention in preventing airline crash. Therefore, the entire airline mode of operation is risk prevention. Checklist after checklist after checklist, pre-flight, during the flight, and so forth. You would never take off when there's a risk. That's why within short 120 years, we have created the safest mode of transportation in the world. The animals and cars kill more people on the ground than the airplanes at 40,000 feet. Another successful example is the fire. When we graduated from caves and lived in the structures, we realized that fire is a possibility. Therefore, we have created and adjusted our lifestyle to prevention of the fire. We have fire extinguishers. We teach our kids how to prevent, how to escape. And that's why Sears Towers, Empire States, all these skyscrapers have stood tall for decades, because we have adopted our lifestyle, our mindset to prevention of that event. In current healthcare model, that I call it the sick care model, we focus just the reverse. We wait for the obesity happen. We say, oh, we have bariatric surgery for you. We wait for diabetes happen. We say, we have insulin for you. We wait for arthritis and musculoskeletal. We wait for the heart attack, chest pain. We say, oh, we're going to stent you. Where now scientifically we know that we have more information about the risk factors of all these chronic conditions than frankly we know how to treat them or how to cure them. However, for this left side of the bow tie, we have financial institutions called hospitals that they benefit from doing the sick care system, right? Sick care services. What BowTie aims to do is to create the basis of an institution that benefits financially from preventing these chronic conditions. My aim is, as I said it in my website, our aim is, our goal is for all of our members never become a patient. And biologically, again, I'm a surgeon scientist, it is possible for the majority of the condition that is affecting our population. It's possible for obesity, diabetes, musculoskeletal, cardiovascular, what have you. So that was the concept of BowTie.
Thank you. That was great. And we're all patients at some time, right? I mean, we're all dealing with health things, whether you're a surgeon.
We are consumers of healthcare. You're 100%
that's a better way to put it. We're all consumers of healthcare. Charles, I see, actually, Dave, your hand was up. Dave Westbrook. Brock.
Hi, Dr. Daneshgari. I really appreciated your presentation. I have a system that I've had now for about the past 2.5 years that's, I would say, a carbon copy, both in recruiting independent physicians and having them publish their fees on our website, but also going after and trying to sign up self-insured companies. So I'd say we are aligned almost perfectly. My issues and my challenges right now to try and go to market are to get primary care physicians. Most of them now, of course, are working for hospitals. I think that's going to change as people become more disillusioned. But a lot of them are going into direct primary care and semi-concierge care. And I'm having a great difficulty, getting independent primary care doctors signed up. So I can't go to market until I really have primary care doctors. I have so far one. I have 34 other doctors, but so far just one primary care doctor. How do you get around that? How have you handled that challenge?
I think the conversations, frankly, I have with the doctors, because I believe the two victims of this sick care system, dysfunctional sick care system, are all of us consumers or patients when we need that. The second one are the providers or the doctors, because no doctor went to the hospital to become a cog in a wheel of a financial institution. I believe every single doctor went to medical school with the intention and the desire to help people, to improve the health of them. So that is number one, kind of the principle. The second principle is we have to basically, as I mentioned in the BowTie concept, we have to create business models that are attractive and doable for those doctors. The reason the hospitals have been able to attract and recruit the doctors is because, again, there's another dirty secret factor, and I'll explain to you, is A, they give them more money. The reason they can give them more money, because the Medicare came up with this rule that if a clinic is basically is run by the hospital can charge more. You're familiar with the concept of facility fees. And I'll tell you how my eyes opened to this. I opened a clinic in this new field I have founded, and I'm running the clinic. 3 months later, and the guy comes in and puts a plaque on the door of the clinic. This is the extension of X Medical Center, is the hospital. And I said, wow, this is a very long extension cord because we're about 10 miles away. And he laughs. He said, yes, it is. I said, why do you do this? He says, because now we call in this clinic as an extension of the hospital. Now we can charge facility fees. I said, how much are the facility fees compared to my fees as a consultant, as a specialist? Well, so your fees for a visit is about $150, $200. The facility fees are between $700 to $800. So we learned that. So when we go to hire the next set of the doctors like myself, we say, doctors, listen, for exactly the same thing you're doing today, we can collect 3 times more revenue when you join the hospital, right? So of course the doctors sign up because they want to make more money. So we have to reverse this financial business model. And I'll tell you with the primary care, is the first direct primary care that I created here, the math was very simple. The doctor was making, and I'll say the numbers. We were making 200,000 a year, a primary care doctor, right? And he was seeing 50, 60 patients a day. He wouldn't go home until 8, 9 p.m. at night. So in the direct primary care, we brought in 500 members. Each member was paying $100 per month. That made it 50,000 per month, 600,000 a year. That doctor paid about $300,000 overhead for hiring the nurse and the rent and so forth, and he took home 300,000. The main difference was now he would see 10 to 12 patients a day. He had time to spend with them. So financially, I resolved the income issue for the primary care. Quality of work, he had much better quality. He enjoyed, he had relationship with it. He went back to his roots of being the doctor. That is the dialogue that we need to have with the primary care. And as you know, the whole direct primary care model is expanding very rapidly across the country because the primary care doctors, although they were attracted to the hospitals, they don't like what they're doing now. Even not only that, the hospital, the specialists don't like to do that because most of us went to medical school to be able to earn a decent living and help people out. So I'm actually very optimistic that this movement of primary care, and I'll give you some validation. Actually, it's market validation as three evidence. One is Walgreens bought a physician group called Village MD, right? If you go through the Walgreens, you see the Village MD. So they separated the primary care from the hospital. CVS bought a group of primary care groups called the Oakleaf for $10 billion. Amazon went and bought a primary care group called One Medical. I think the writing is on the wall that this movement has started and the primary care basically will come toward the consumer and will separate from the hospitals if there are innovators who are willing to take the risk and develop the business models and carry on the risk.
We've had a lot, I think Northeast Ohio then must be much different than Southwest Ohio because, Cincinnati is very conservative, buttoned up area, demographic. I'm in Dayton and again, numbers are very small. All the things that you said, I have discussed with primary care doctors. The problem is when they leave the hospital systems, because they're just going on with the kind of things that we've been talking about. They go into practice and they become so busy, they don't need me. They fill up their practices within a year. So I really don't seem to be able to appeal to them. And then larger groups of primary care doctors, of which I tried several, they just keep putting me off. So that's been my challenge. I agree with you, everything you've said, but when it comes down to it, it's very difficult. Doctors are by nature conservative. I felt that they have signed so many contracts, particularly HMOs, that they feel that they don't want to get hoodwinked.
David, my short answer, and I don't know what kind of business you are in so forth. My short answer to this is, in general, frankly, doctors are not good business people. And therefore, and I include myself into that, is you have to kind of create a model for them and help them out. Otherwise, it is basically you're in disadvantage because the independent doctors, if they don't get into a new business model that basically realigns them with the nature of what they want to do and realigns the financial direction, they're in disadvantage in competition with these big health systems. As I mentioned, these big health systems, they have grown in their revenues by 400%. So they add the facility fee, they make a lot more money, therefore they can offer more money. The competition here is not based on the money. The competition has to be based on the value sale that you have to sell to the primary, to the doctors And in long term, the value will turn into a better financial reward for them and for those of us who are taking the risk. So that is in my kind of the big picture.
Yeah, well, just to give you some of my background, I've been an endocrinologist now for 50 years. So I'm retired from active practice, but you know, it's not a business plan. I've done just about everything I can. So it's realizing that I'm no businessman.
Yeah, sure. It seems that yeah.
I was gonna say, maybe you guys could take this up offline,
Mhm.
so we
Sure.
can get through, we're coming up on time here. Thanks. Charles, your hand's up. Charles Froman.
Mr. Ford, you're next after Sharon, I think. So, you know, Forbes magazine featured how our brokerage combines a competitor of yours, you know, and we have an in-house shopping service we call the concierge. And, you know, we promote not insurance, but medical cost sharing. And through something called an ICRA, the Individual Coverage Health Reimbursement Arrangement, we are expanding sharing to larger employers who often don't want the self-insurance option, which the Rosetta brokers are all promoting for the right reasons. I mean, there are so many advantages and benefits to self-funding because it keeps the employer in the risk business, whereas ICRA basically individualizes health plans that you can take with you when you leave the company. So what really accomplishes the individualization of health policy ownership. That said, what you've presented here for BowTie leads to my question. So I agree with you that the subscription primary model creates time. That's the word you used. And we can talk about that. That's huge. It changes the dynamic. It ends overutilization. It resolves 90% of episodes. Great entry point control for healthcare. And the shopping service, critical to get those well-priced labs, tests, and specialist referrals. And the shopping help using Blue Book or ADX therapy. There's so many tools. They're not perfect. You know, it's, you know, admittance rates. It's, you know, who's the good surgeons? I think you would agree it remains an open question, and it's really hard to figure that one out. And the self-insured employers can pick better local hospitals that are maybe underutilized or specialized here and there. I mean, your model can really help patients. We haven't gotten to one of the attractions for today's event, though, and that is hospital competition. The three things you mentioned will pressure hospitals from loss of overutilization to clean up their act, perhaps. But what about repealing certificate of need laws to allow physician-owned hospitals, to allow more integrated hospitals, homeopathic hospitals like we had 100 years ago? Competition. What are your comments on that?
Number one is you mentioned a lot of basically innovative concepts. The ICRA, the Individual Coverage Health Reimbursement Account. You mentioned the Rosetta, which is a number of advisors for the brokers who kind of bring together the point solutions for employers, the self-insurance. So each of these technicalities of restructuring the business of healthcare, in my opinion, are welcome, and each of them, they have their innovative aspects. I think underlying this whole concept is basically, are we as a nation, we are moving toward a free market-based delivery of healthcare, that the elements compete with each other based on the quality, based on the price, and based on satisfaction of the consumer. So going back to the comments you made about who's the better surgeon, frankly, a good surgeon is defined by the consumer, not by the CMS metrics, all right? But we are in the beginning of this movement of free market offered. And as you said, I'm very, very familiar with the health sharing. I've worked with the number of the major health sharing organizations. You know, there's some good and bad apples there, as you know. We've had some bad apples here in Ohio. We have had very good ones. The Christian Health Ministry. There's a Medishare in Florida. There's a Sedera in Texas. So I've worked with all of them. I know the
And
founders
Zion.
and so
Yeah.
Zions, yeah.
Yeah.
So to me, the big picture is: are we moving toward the free market, basically delivery of healthcare? I hope we do, and I think the 2024 presidential election is going to be a turning point for that, because at the conversations I've had with some of the interested people, is that is going to be definitely on the campaign, because frankly, it's not because of my wishful thinking, it's because we as a nation no longer can afford the current sick care system. We are increasingly, again, this year we spent over 13,000 per capita. The Europeans are spending less than 6,000. The federal government that pays only 1/3 of the healthcare needs of the population, it consumes close to about, now it's getting close to half of the federal budget. We are spending, in the federal level, we are spending twice on the healthcare than we are spending on our defense. At the country, we are spending 5 times more on healthcare or the sick care than we are spending on defense. On the defense part, we have the mightiest force in the world. No one dares to touch us. In the healthcare, we are delivering, some of the poorer quality. The point I'm trying to make is we have no choice but to correct course, to decide whether we're going to, which path we are going to take. I think we all agree on this panel that the free market based delivery is the way to go, because as we've done it, we have brought efficiency to every other sector of our lives, from electronic, technology, house, transportation, and so forth. If a single period model wanted to work, the Soviet Union would have been still a superpower, in my opinion. And I've written that in my book. As I mentioned, I have written this book on the health guardianship. Going back to your specific question on the certificate of need, I agree. I think that is one of the point of the innovation or regulatory change, regulatory headwind that this free market has. And that's why I brought up the 2024 election. There are a number of elements that I think I will believe within the first 100 years of hopefully the next administration would be issued, very much like President Trump issued, the whole price transparency law. Within 3 years, although the hospitals are cheating through their teeth with this concept, but at least brought up the whole basically price transparency on the table, right? Now the hospitals are obligated to disclose what they're basically charging. They're obligated to accept cash paying, which goes back to the health sharing need you have. Which one of this technical innovation is going to lead to the ultimate successful model of a free market? Frankly, I don't know. And frankly, at this point, I don't care. Again, I make an example to my team that the current space in the healthcare reminds me of 2 spaces we've gone before. One is between 1975 and 85, when the writing was on the wall that the power of computation is coming to personal lives. Personal computer was being born, right, between 75 and 85. Again, the solution didn't come out of the governments or the big corporations, the IBMs. The solutions came out of the garages in Silicon Valley, right? And the result, we have 2 or 3 major companies. The other area is between 1990 and 2000, when the power of internet and online shopping was being born, and boom, again, as a basement of Jeff Bezos' house in Seattle is born the Amazon and the Google and so forth. I believe we are in that ecologically, we are in that space for the healthcare. There are a ton of innovations. The BowTie, the Oklahoma Surgical Center, the spaces of innovations that are budding out, the health sharing and so forth. And I think the market is giving us some tailwind. The COVID validated some of the concepts, the virtual care delivery. The previous administration brought the price transparency. And these are going to help basically allow these buds of innovation to grow. And the ultimate product, whether it's going to be the Apple computer or Dell computer, will be delivered within the next, I think, 5 to 10 years. I believe, again, really in the wealth of our nation that will pick up the right choice and we will be successful.
Let me jump in if I can. We have just a few minutes here and 2 questions left. Sharon, do you want to go ahead?
Hi, well, thank you, Doctor. I really admire what you're doing. I think that is definitely needed. I'm a naturopathic doctor, and what I'm finding in my practice is basically trying to correct the damage that has been done from people that have raised and go through the medical system from birth. And frankly, I think the problem is even way bigger than that. It's the paradigm that it's built on, you know, Rockefeller medicine. And most of the chronic diseases and even cancers and things can, through my research, we're finding it stems from when we started vaccinating from day one. And they, you know, now that people are getting vaccinations throughout their whole life. So I applaud what you're doing, but I really feel we need a separation of health and medicine, because medicine and medical doctors and the things they know are definitely necessary. But I don't even work with integrative medicine. I do pure natural medicine, and I'm with a whole network of people that they never go to medical doctors. They would only go if they were unconscious to a hospital, that type of thing. And
yeah, Sharon, my answer to, I don't know if you have a question or a comment, but my kind of response to your comment is, again, we entire sick care system, I call it the sick care, we call it medicine, has been focusing on this left side of the bow tie. We're waiting for the diseases happen. And we are spending over $4 trillion. Again, the data, the science research shows half of it is a waste. If we, through these innovations, we succeed in saving this waste, $2 trillion, and we start taking our focus and attention to the right side of the bow tie, focusing on basically health, guarding the health. And then there is more than plenty resources to deliver into alternative processes or alternative approaches, such as naturopathic, such as integrative medicine, all that stuff. The problem, the fundamental systematic problem is, again, like the Soviet Union, is there are misalignments. The system is so basically is like a drunken sailor. They're making so much money out of the sick care thing, and they're consuming so much of resources of our country that there's pennies left to go and explore the other path that could keep people healthy.
Thanks. Thank you. Charles Ford, last question. Oh, make it short if you can, if you can.
Well, I'm going to make it short because everybody's got better things to do than listen to the likes of me. But at the risk of saying that, I grew up in a place where when the first frost came, you slaughtered the pigs. Our health system today is a fat, overweight pig, which is what was just described. I admire all the things that I hear week after week after week, but the fundamental problem is you're putting lipstick on a pig. The solution to a pig is you slaughter it. Now, what are the 2 problems in our system that are not discussed today? The number 1 biggest problem is government. Government runs it, government funds it, government debits it, government determines who the outcomes are, what we do, who we do, when we do, how we do. You cannot have a health system in competition where government is top-down central planning. That will not work. It is inimical to any free enterprise system. What is the second problem? What is the second leg? The second leg is the supply of doctors. I'm sorry for the individuals speaking today. I'm sorry I can't pronounce your name. But where is it written that a sawbone should make $300,000 a year in the practice of medicine? Where is the great word, the great truth that it has to be that way? No, it should be driven by market. And I suspect the market may not go down to $1,500 a month. It's where I think it should be, but it's certainly not going to be $300,000 a year. So why do we have $300,000 a year? Because we don't have a supply of doctors that would drive that cost down. Why do we not? Because government and the AMA make sure we don't. We go back to the certificate of need that Charles talked about. So my point to everybody on the phone today is all these slapping lipstick on the pig works to a certain degree. But until you slaughter the pig, you're never going to have improvement and innovation. And ultimately, the system shall collapse, just as it did in Soviet Russia, for precisely the same reason. Thank you.
Thank you, Charles. I think we're all in agreement on that. Firouz, you want to say anything?
No, I think yes, as I think we all are. I've written in I said it in my book. There's 300 million stories about the sickness of the sick care system, and there is a copy of the USA Today. My office says this is February of 2020 that 92% of Americans think the system is sick and needs to change, and I think that is my concluding remarks that. We are smart and we know we have a problem, and this buzz of innovation have started, and that is how, frankly, the system changes. Whether it leads to the slaughtering of the pig or not, it is how the new value and new wealth is generated, and I think the time has come for the health. And the last piece of it is, if we do this correctly, the rest of the world will follow us, as we did again in personal computer revolution and in online revolution. And as a result, we created 4 or 5 companies that are darling to our economy, and they have generated more than $1 trillion in wealth.
Would you hold up your book again so we can see the title? Just everyone there.
It's called Health Guardianship, the Remedy to the Sick Care System.
Beautiful. And how can people read? How can they reach you?
It's available on Amazon.
Of course.
Amazon and
How can people reach you? Or your website?
I'm on my website is BowTieMedical.com, and you can find me on LinkedIn, or BowTieMedical.com is where you can reach me.